Important thing, I think it has been covered in parts. There are two types. One is fibrosed and one is normal posterior capsulorhexis. So the vitrectomy settings, as you could see here, it was a very, in a normal posterior capsulorhexis, it was a very high cut rate, almost 2500, and then you get a very round, with a 23 gauge, you get a round capsulorhexis, and if it is a fibrose, a lower cut rate and higher vacuum. Yeah.
Another small tip, if you stain the anterior capsule, make sure you don't put too much stain, because if PC gets stained, your access is difficult. And while operating, if it's the glow is not good, you can adjust your retro illumination. You can switch off the main light and only use retro illumination, which really helps with your posterior access.
Thank you. And next we have Dr. Kavitha, and she would be speaking on. This is again a major section of pediatric cataract, which is traumatic pediatric cataract.
Very good afternoon, and thank you, Dr. Love, for this opportunity. So, pediatric cataract itself is very challenging, and on top of that, managing trauma in the setting of children's eyes is double challenging, right, as we all know. And pediatric traumatic cataract, I'm going to just brush through some challenges we face and tips that we can follow. So, trauma, like first, it is step by step we have to manage. So first is to restore the integrity of the globe, if it's a globe trauma. Second is to restore visual axis, clear the visual axis, and then optical correction and amblyopia treatment. This is the order with which we should follow. So as we know, trauma can be blunt or penetrating, and all sorts of presentations can be there, depending on where it can be present to you at emergency as soon as the injury occurs. It can present at various times after the injury in various aspects. And blunt trauma, the common features are intact cornea, if not too severe. Total cataract is common. Iris issues can be associated, like sphincter tears and dialysis, etc. Lens stability is always a query. And posterior capsular status, you have to be wary of, even if anterior capsule is intact. And angle anomalies, angle injuries can also be coexistent. And of course, posterior segment issues should be looked into by other modalities like ultrasound. And after the surgery, if the visual axis is cleared, then you have to take a look into the fundus to see concurrent posterior issues. Penetrating trauma typically causes more of corneal trauma. Capsular integrity, again more of anterior capsule involvement, and if severe, including posterior capsule can also be involved. Iris trauma can be there. So we, as I said, we have different scenarios to face. So we have to plan how, when, and along with what the surgery for cataract is managed. So what are the issues we see? Cataract management, when do we do? Whether we do it at the primary repair when there is concurrent globe injury like a corneal tear. So if not, then timing between the trauma and the cataract surgery. When they present to you, at what stage do you manage the cataract surgery? And if you manage the cataract surgery, do you plan an implantation of the IOL primarily or secondarily? And if IOL implantation, where do you place it? And if there are additional issues, when do you plan that? And of course, every point you need to take the patient into your this thing, and you have to counsel. And if it's a medico-legal issue, that also has to be parallelly taken into account. So these are a few different issues, different situations, like 2-day-old injury, 1-week-old injury, 8-month child, bicycle injury. So all sorts of presentations. On the right side, you see a repaired corneal tear, and there is a cataract. So issue 1, like I said, cataract management during the primary repair. Do you ever have to do that? So usually no. Why not? Obviously, when there is an open globe, you want to make the globe intact first. And emergency state, you may not be in a position to do a cataract surgery. You may not be having a good instrumentation, anesthesia, all that issues. So emergency state, you try to manage only the globe. Availability of expertise, etc. is always a problem, and risk of inflammation and infection is always a problem. So cataract management during primary repair only if there is a breached anterior capsule with loose cortex in the anterior chamber, and just in case you want to really avoid multiple surgeries, if that is the only few indications, and you can do an early rehab. So a very small peripheral corneal tear along with a ruptured capsule, maybe in that situation you can remove the cataract along with the corneal repair. And you can do an immediate posterior segment assessment if you know, if you remove the cataract. So cataract surgery during primary repair is best avoided, done only if there is a large breach in the anterior capsule. So if you implant IOL during primary repair, ideally never, but very few situations. See here you see there is a very peripheral injury 2 days prior, and here there is a very small inferior corneal injury, but centrally cornea is intact but capsule is fully ruptured. So only wound repair is done in the first situation obviously, but second situation, if it is an older patient and if other situations so that you are able to get a good DBR, maybe a primary IOL implantation can be considered, but usually you don't consider. IOL implantation with primary repair, like I said, is best avoided. There's obvious reasons of infection and biometry issues. So if cataract is not managed during the primary repair, then when do you manage? So timing between trauma and cataract surgery in a child is very, very important. So when we do it, next day, next week, next month, how do you decide what are the factors? So age is the first criteria. So as younger the child, you want a visual rehabilitation as soon as possible with a dense opacity in the lens. And if there is an inflamed eye with loose cortex and all that, inflammation and IOP issues is a factor which tells us what time, when to decide and do surgery. So this was a 2-day prior repair done, but you can see it's an inflamed eye. So we went ahead and we are not thinking about IOL or anything, but to control the inflammation and let the eye heal, we do a lensectomy and remove the cortex. So these are different issues. So timing of cataract surgery and IOL implantation. So you do a cataract surgery, but whether to implant IOL or not, again as a primary. So corneal injury determines when we implant the IOL, whether during the cataract surgery or after the cataract surgery as a secondary procedure. So if there is a sutured cornea, you have to wait till suture removal for at least 6 weeks and then get a good DBR, ideally 2 weeks to heal after the suture removal, and then plan your IOL implantation. So what factors decides? Like I said, PC status. If PC integrity is not good, then either implantation in the sulcus or you can leave the child aphakic, let the sulcus rim form nicely and plan a secondary IOL. Corneal sutures are the main factor. If it is sutures are present, then you have to wait for the suture removal to get a DBR, so you have to probably do a secondary IOL. So in the bag implantation versus in the sulcus or AC IOL, SF IOL, these are options when again the capsule integrity is the main issue. So despite having a central posterior block kind of a thing following a cataract surgery, if you're able to get a nice central clear PC opening, then you can implant IOL in the bag in the situation even if it is trauma. But here there is a PC block, but there is an anterior capsular block also, so we're not having a very good bag. So here the IOL is implanted in the sulcus. So this is like a more or less a fused capsule, cortex, everything is fused. There is even a vascular membrane there which you have to cauterize if you anticipate bleeding, and then cut, form a rim and insert the IOL in the sulcus. So these are the few situations where IOL is in the bag or in the sulcus. So non-cataractous role, what I mean is if cataract is associated along injuries associated with the iris issues, then see in the first situation there is a dialysis, in the second situation there is a paracentral corneal opacity. So you need to manage that as well. So there are procedures like small procedures, but important procedures like optical iridectomy, iridodialysis repair, glaucoma surgery sometimes, and vitrectomy, all that can be indicated to be done parallel or along with a cataract surgery. So this child so you have a severe blunt injury associated with a small peripheral penetrating injury. So there is no pupil. The pupil iris is fully stretched. So a pupil had to be formed literally with a cutter, and then you find an intumescent total cataract. So you are actually doing a pupilloplasty along with the lensectomy. In this second situation, you see a corneal opacity almost touching the center, but there is a good peripheral clear cornea, so you can utilize that area. As you do the cataract surgery, you can do an iridectomy to enlarge the pupillary opening to get a better clear visual access. And here we see iridodialysis. So many times we see situations where cataract is associated with the iridodialysis. So you have to decide if it's a very small, you may decide to observe it. So if you have to do, then when do you do it? On table, you have to do it first. You do the cataract surgery, which is a more delicate surgery. Later, so once you're very sure about the cataract surgery with a good IOL implantation, then it's better to do the iridodialysis repair, but you can do it in either order. So long-term managing trauma in children, continuous challenge. Refractive changes keep happening. Amblyopia has to be managed every point, and glaucoma has to be looked for and addressed whenever you notice it, and retinal complications has to be addressed. And strabismus, of course, any unilateral issues can be associated with strabismus, so that also has to be addressed. So the take home is you manage the cataract, but best avoided at the time of primary repair. Ideal timing is 1 week to 1 month in adults as well as children. So amblyogenic age, it is crucial to clear visual access, but not necessarily to implant IOL as soon as you think you have to do. The DBR issues are more important than giving a IOL implantation. Primary IOL implantation has proven to give best visual outcome at all cases. Concurrent issues, whenever present, has to be looked for and managed as you manage the cataract. And long-term issues like glaucoma and retinal complications should always be looked into, and sympathetic ophthalmia as well. Thank you.
Thank you, Dr. Kavitha. One thing regarding, especially in open globe injuries, if you're doing a primary thing, do you use a intravitreal antibiotic?
Not only if there is any not much posterior involvement, mode of injury, like if it's a clean injury, we don't.
Any question? Yeah, I've been giving.
No, we are not giving. Not.
No, I've been giving in all. No.
I think in
All
Shankar
cases.
Netralaya we are not giving.
Actually, Desha group has a very large study regarding intracameral amoxifloxacin. I think yes, you can put.
In children, sir?
No, all the cases.
Almost similar result that is Orvind published that paper we have published also that our chances of endophthalmia is reduced by uh, yeah, because it is our habit. Probably we'll give all, especially in traumatic cases, we give routinely.
Yeah, trauma, I agree.
Yeah, Dr. Vaishali also there.
So like you, every single case.
Every single case. No one want to take any chances.